Continuing on in Unit 4, Part 6, Hepatitis B. Hepatitis B is a viral infection affecting the liver. In the mom, she may be asymptomatic or she may be acutely ill with a chronic low-grade fever, anorexia, nausea, and vomiting. Hepatitis B may cross the placenta and infect the fetus. So upon delivery, the treatment for the fetus is to give them the hepatitis B immune globulin or HBIG vaccination and immediately start the hepatitis B series on this child. Obviously, the baby needs to be washed up prior to the administration of these vaccines so we don't inadvertently transmit the virus across the skin membrane. HIV, again, is a virus that will eventually cripple the immune system. It can affect the infant by crossing the placenta, by contact with maternal secretions during labor and delivery, and also through breast milk. Nursing care is counseling and support to the mother that is HIV positive, again stressing the importance of taking her antiretroviral drugs to decrease the chance of the HIV virus crossing the placenta and infecting the unborn fetus. Education also needs to be done to decrease the exposure of HIV to other individuals. And again, stress the importance of antiretroviral medication while pregnant and in labor to reduce the likelihood of transmitting that HIV virus to her unborn offspring. She will need to bottle feed and not breastfeed with HIV. Group beta strep is not a sexually transmitted disease. It's a bacteria that's found in approximately 70% of all women in the rectum, vagina, cervix, throat, and on their skin. It is the leading cause of neonatal mortality. GBS is screened for between typically the 35th and 37th week of pregnancy, and we treat it with antibiotics either before and or during labor to not get rid of the infection in the mom, but actually to provide protection to the unborn offspring. Urinary tract infections are very common in females due to their short urethra and proximity to the rectum. Pregnancy alters the self-cleaning action of the urinary system. Urinary tract infections could be symptomatic or asymptomatic depending on the individual. Asymptomatic infections of UTIs can actually lead to cystitis, which is inflammation of the bladder, or pyelonephritis, which is a kidney infection. Urinary tract infections are treated with antibiotics, and it's important for you as the nurse to educate the patient on excellent genital hygiene. Another condition that can affect pregnancy is hyperthyroidism. It is rare in pregnancy. However, pregnancy does mask the signs and symptoms of hyperthyroidism because they are similar to those that commonly occur during pregnancy. Lab tests are very useful in diagnosis, include the T4, T3, and TSH levels, and treatment includes the PTU medication, which can cause across the placenta and cause fetal hypothyroidism. Hypothyroidism in the mom must be treated during pregnancy because it is linked to decreased mental ability in the fetus to a mom that is pregnant and has untreated hypothyroidism. The most common cause is Hashimoto's thyroiditis. Untreated hypothyroidism increases the risk for miscarriage, preeclampsia, gestational hypertension, placental abruption, preterm birth, and stillbirth. The lab tests are the same as hyperthyroidism, including the T3, T4, and TSH. And the treatment of hypothyroidism is oral replacement with Synthroid or levothyroxine daily. Maternal PKU. PKU again is an inborn error of metabolism caused by an autosomal recessive trait resulting in the deficiency of the enzyme phenylalanine hydrolase. What happens with PKU is there's a toxic accumulation of phenylalanine which can lead to impaired brain development and function. So the patient must have a dietary restriction of protein foods during pregnancy. The phenylalanine levels in the mom should be monitored at least weekly during pregnancy, and individuals with PKU should not breastfeed. This is on page 311 in your book, which is in chapter 13. Objective 85 says predict nursing care of women experiencing surgery or trauma during pregnancy. The most common non-gynecological surgery during pregnancy is an appendectomy. The signs and symptoms of it include right lower quadrant pain, nausea, and vomiting. The other classic signs and symptoms are not reliable during pregnancy because of the change of the anatomical structures. Hospitalization care, we do fetal monitoring for fetal heart rate and uterine contractions before and after surgery, and these individuals may need to be placed on a tocolytic because surgery may irritate the uterus and cause contractions. And discharge teaching for an appendectomy or any type of surgery during pregnancy include care of the incision, temperature assessment, resumption of activities, signs and symptoms of preterm labor, their diet and elimination, signs and symptoms of developing infection, and follow-up visit information as well as any medications. Again, this is just a typical discharge from anybody having surgery with the addition of the signs and symptoms of preterm labor. Objective 54 says explain the maternal and fetal effects of specific anemias and provide medical and nursing management during pregnancy. With anemias, anemia is the most common medical disorder of pregnancy. Treatment of anemias during pregnancy is important to prevent the need for blood transfusions and infection in the postpartum period. There are 4 different types of anemia, including iron deficiency anemia, which is the most common type, folate deficiency anemia, sickle cell anemia, and thalassemia. With iron deficiency anemia, it's the most common anemia of pregnancy. The lab tests we look for iron deficiency anemia include hemoglobin, hematocrit, and ferritin levels. The treatment, it is preventable if individuals would eat red meat and green leafy vegetables. And also we can take iron supplements such as ferrous sulfate. It's important to take those supplements with vitamin C to increase absorption and not to take them with dairy products, which decrease absorption of them. Always make sure you educate the patient that their stools may be black and tarry with iron supplementation, which actually can mask the signs and symptoms of a GI bleed. Folate deficiency is caused by a lack of folic acid in the diet. It can be prevented by taking a prenatal care vitamin supplements, which have the required 400 to 600 micrograms of folic acid per tablet. Pregnant women that may require higher doses of folic acid include women that have multiple gestation, if they're taking any anticonvulsant medications, or if they have significant hemoglobinopathies. The treatment for folate deficiency is folic acid supplements, and it often occurs with iron deficiency. So we'll have them on folic acid supplements as well as ferrous sulfate. Sickle cell hemoglobinopathy is a recessive hereditary familial hemolytic disease caused by the presence of abnormal hemoglobin affecting persons of African or Mediterranean descent. The normal sickle cell hemoglobin has a lifespan of 5 to 10 days instead of 120 days. A sickle cell crisis is when these sickle cells basically clump together, and the patient will have fever or pain in the abdomen, joints, or extremities. It can occur in any organ system and is often triggered by dehydration, hypoxia, or acidosis. And so it's important for these patients with sickle cell disease to remain well hydrated, good oxygen levels, and make sure their diet's within normal range. Individuals with sickle cell disease are at risk for miscarriage, intrauterine growth restrictions, stillbirth, preeclampsia, development of urinary tract infections, and lung infections. The medical management of sickle cell disease during pregnancy includes serial ultrasounds for fetal growth and non-stress tests in the 3rd trimester. Sickle cell crises are treated with analgesia, oxygen, and hydration for fever reduction. Nurse interventions for somebody with sickle cell disease and having a crisis, side-lying position in labor, nurse interventions for somebody with sickle cell disease, a side-lying position in labor, using supplemental oxygenation, ensuring the adequate hydration, making sure the patient has an epidural or spinal or epidural for pain management, and a vaginal birth is preferred. Just to remind you what sickle cell hemoglobin looks like, in the top portion A, that's a normal red blood cell with normal hemoglobin, and on B, which is the bottom portion, is the sickle cells, and you can see how they would clump together and potentially cause a crisis formation. We worry about crises in the placenta because if the crisis occurs in the placenta, the developing fetus will not get good oxygenation. Sickle cell trait is sickling of red blood cells with a normal red blood cell lifespan. So they're sickled, but they last 120 days. These individuals typically do well in pregnancy. They are at increased risk for preeclampsia, intrauterine fetal death, preterm birth, low birth weight infants, postpartum endometritis, which is an inflammation of the uterus, urinary tract infections, and iron deficiency. Thalassemia is a hereditary disorder involving abnormal synthesis of hemoglobin. With the heterozygous form, it typically does not worsen with pregnancy. With the homozygous form, this is the more severe form of the anemia. Infertility is very common with these individuals, and if pregnancy does occur, the mom may have severe anemia and congestive heart failure, which is common with the homozygous form of thalassemia.